Hi, my name is Dr. Elizabeth Constance. I'm a reproductive endocrinology and infertility specialist at the Heartland Center for Reproductive Medicine in Omaha, and I lead our fertility preservation program there. In that role, one of my primary areas of clinical and research focus is on fertility preservation before cancer treatment, as well as monitoring the return of natural fertility and treating infertility when needed after cancer treatment, which will be the focus of this discussion today. So thank you so much for participating and for inviting me to participate as well. So, I have no financial disclosures. In this talk, we will discuss the off label use of hormone suppressing medications to reduce risks to women with a history of breast cancer undergoing certain types of fertility treatment. So, our objectives today will be first to review fertility and reproductive function. Then, we'll describe how various cancer therapies impact fertility potential and reproductive timeline. And finally, discuss strategies for monitoring post treatment reproductive function and interventions to preserve future fertility. So, let's start then with female reproduction. The female reproductive tract consists of the vagina, uterus and cervix, fallopian tubes, and ovaries. The ovaries serve two key important functions. The first is that they make hormones like estrogen that are important for bone and cardiovascular health. And the second is that they house the resting pool of eggs, which are necessary for conception. So, just a quick overview in a typical menstrual cycle, you have the resting pool of eggs here in the ovary. Each cycle, a group of eggs in both ovaries get activated. One of those activated eggs then is selected at random to become the dominant follicle that's going to mature, and then that egg will get released midway through that cycle. The egg is picked up by the fallopian tube here, where if sperm is present, the egg and sperm will meet in this mid portion of the fallopian tube, which is where fertilization occurs. And then a fertilized embryo will make its way through the remainder of the fallopian tube and then implant in the uterus, where it would potentially grow and develop into a term baby. Both the egg number and the egg quality play important roles in fertility, and abnormalities in either of these, either the egg number or quality, can result in reduced fertility potential. So, the term ovarian reserve is used to describe the relative egg number in an individual's ovaries. This is based on the fact that women are born with all the eggs they have for their lifetime, and that number goes down over time, starting even before birth, which is super unfair, but just the way our bodies are built. Either a lower than expected starting number or an accelerated rate of decline can result in low ovarian reserve. This can lead to both difficulty getting pregnant as well as earlier than expected menopause, which is when menstrual periods permanently stop and represents the end of a woman's ability to conceive using her own eggs. If we focus now on the portion of the graph that represents a woman's reproductive window, or the time in life when pregnancy is most likely, we can see that natural fertility begins to decline around age 35, with significantly decreased reproductive function after age 40 due to a decrease in both egg number and quality. As we mentioned previously, all the eggs available develop before birth and are then paused in their development until the time they are selected to be released or ovulated and potentially fertilized by sperm. The longer they are in this resting or paused phase, the less efficient the machinery inside the egg responsible for replication of genetic information is when it begins working again at the time of ovulation. This is the process we are describing when we talk about egg quality as opposed to egg number. This decrease in egg quality, or the efficiency of that replication of genetic material, leads to both decreased pregnancy rates and increased miscarriage rates over time, which is that red dotted line. Unfortunately, treatments like chemotherapy and radiation can accelerate this process of egg loss, sometimes leading to infertility and early menopause. So, chemotherapy and radiation are very successful at treating cancer because they target and attack rapidly dividing and metabolically active cancer cells. The possible downside is that they can't tell the difference between rapidly dividing metabolically active cancer cells and other rapidly dividing cells like those in the ovaries. To the best of our current knowledge, once these hormone producing cells in the ovaries that support egg growth and development are lost, they cannot be regenerated. The extent of this damage is dependent on one's age at the time of treatment, her pre-treatment ovarian reserve, the chemotherapy agent or agents used, and their cumulative dose. Radiation therapy can also have a similar toxic effect on the ovaries through direct cell damage and cell death that is also dependent on the dose and the duration of treatment and the woman's baseline ovarian reserve. Finally, pelvic and abdominal surgeries can have a direct effect on fertility as scar tissue can alter the anatomic location of ovaries and fallopian tubes, which can affect normal egg transportation and reduce fertility potential. So, this is a really helpful resource from savemyfertility.org. This table shows common chemotherapy and radiation protocols and separates them into high, intermediate, and low risk categories in terms of risk to fertility after treatment. There are separate tables also available for men and for children. It's important to note that the percentages listed for each of these classifications are the rates of ovarian failure or early menopause, not infertility. We know, however, that some women who do not go into early menopause following treatment will still experience infertility requiring medical treatment. So the impact of these treatments on fertility in general is likely even higher than what is listed. So, for women who have already been through cancer treatment, an evaluation to assess post treatment ovarian reserve can be super helpful, even if they are not yet ready or don't ever intend to have children. First of all, I'm a strong believer that the more information you have about your body, the more empowered you can be to take control of your reproductive health and future. Even if having children is not something you have any interest in ever doing, which is the case for many individuals, the premature decline in hormone levels associated with early menopause can have profound negative effects on bone and heart health. So, identifying a potential issue early can allow us to intervene and protect your long term health completely separate from reproduction. For those who may want to have children now or in the future, identifying a decreased ovarian reserve or risk of early menopause can allow us to take steps to preserve future fertility if desired. Ovarian reserve can be assessed using an ultrasound to look at the ovaries. Eggs are too small to be seen by our eyes, but what we can see are these fluid-filled sacs called follicles, which are the sacs that eggs grow in within the ovary. As you can see here, these kind of dark black circles, I call them the chocolate chips in the chocolate chip cookie, are the follicles that we're looking at. On ultrasound, we can count these small follicles, which represent the number of activated eggs at any given time. We can also assess ovarian reserve through hormone testing, specifically looking at a hormone called AMH, which is produced by the support cells in the ovaries that surround the resting pool of eggs, and FSH, which is the hormone the brain uses to communicate with the ovaries to grow and mature an egg to be released each month. This table then shows the normal ranges for the hormones AMH and FSH. As the ovaries begin to slow down due to low egg number, we see that AMH level decrease. At the same time, the brain starts having to kind of shout at the ovaries to be heard. And so we see the FSH levels go up as ovarian reserve goes down. By monitoring these levels over time, we can catch these changes early and potentially intervene if fertility preservation for later childbearing is desired. We typically recommend waiting until at least 1 year after the completion of chemotherapy or radiation to start monitoring ovarian reserve. This is because many people will see recovery of hormone levels during the first year, and it can be normal to take up to a year for periods to return after treatment. Depending on what those initial levels are, we will then typically follow the levels every year. However, more frequent monitoring may be indicated if there's a significant drop or if levels are low enough to consider further intervention. Another really important question that is frequently asked is how chemotherapy or radiation may impact a pregnancy in the future. We typically recommend waiting at least a year after completion of treatment before trying to get pregnant in order to make sure that cancer is in remission and to reduce any potential risk of the treatment itself to a developing baby. The good news is that when pregnancy occurs at least 12 months after treatment, babies born from mothers who've gone through treatment in the past have no additional risk compared to babies born to mothers who have not. Women with receptor positive breast cancer may face the additional need to undergo several years of hormone therapy after initial treatment, which can further delay childbearing. There's currently an ongoing study called the Positive Study, looking at the safety of interrupting hormone therapy to pursue pregnancy. And so far, early data is reassuring, but the study is still underway. Looking now then at male reproduction. So, similar to the ovaries in women, the testicles in men have two primary functions. The first is the production of the hormone testosterone, and the second is production of sperm for reproduction. Unlike women, however, who are born with a fixed number of eggs, sperm production in men begins at puberty and continues throughout the remainder of their lifetime. This is possible due to the presence of stem cells in the testicles that drive continuous sperm production. Sperm is then transported through the epididymis and vas deferens to the ejaculatory duct. Through this transport process, the sperm joins with fluids from the prostate and seminal vesicles, which contain proteins and nutrients that support sperm survival and transport through the female reproductive tract. The process from stem cell to mature sperm in the ejaculate takes about 3 months. Therefore, the negative effects on sperm number or function of medications or other environmental exposures can be seen for up to 3 to 6 months after the inciting event occurs. The effects of cancer therapy on male reproduction and reproductive potential are also similar to those seen in women. In men, destruction of a critical percentage of these sperm-producing stem cells in the testes by chemotherapy agents may lead to either reduced or no sperm production, which is called azoospermia. Once these stem cells are damaged or lost, that process is not reversible, unfortunately. The risk and extent of damage to these cells depends, again, on the chemotherapy drugs used, the dose, and the length of treatment. Likewise, radiation therapy has a direct toxic effect on the sperm-producing cells of the testes in a dose-dependent fashion. Finally, pelvic surgery can impair fertility by impeding normal sperm transit by causing a blockage anywhere along that transport system or through nerve damage. Although it is outside the scope of this talk today, I want to just briefly mention for any of you who may be in support groups or know someone with a new cancer diagnosis that has not yet started treatment, there are often options available for fertility preservation before cancer treatment, depending on the person's age, diagnosis, and treatment plan. So for anybody possibly interested in this, a consult with a reproductive specialist to discuss those options, given their particular situation, can be super helpful. For individuals or couples desiring to conceive following cancer therapy, there are several options which we will discuss in more detail. First and foremost, I want to stress that having gone through cancer treatment in the past does not mean that you can't potentially get pregnant on your own without medical intervention. Although a history of cancer treatment is a risk factor for infertility, many individuals conceive without medical treatment. However, knowing that this is a possible risk, it is helpful to seek early evaluation to assess your personal fertility potential so that intervention for fertility preservation or treatment to conceive can be pursued if needed. So the first therapy option is hormone therapies. And so these are oral or injectable medications that can be used to stimulate egg production in some women. For women who are not having regular menstrual periods but are not in early menopause, medications can be used to induce egg production and ovulation. In women who are having regular periods but are still having trouble getting pregnant, these medications can also be used with the goal of ovulating more than one egg at a time. The rationale for this treatment is that by increasing the number of eggs released, we can increase the chance each month that one of those is able to be fertilized and result in pregnancy. This treatment does, however, also increase the risk of getting pregnant with more than one baby at a time and should be monitored closely by your doctor. Intrauterine insemination is the process by which sperm is placed in the uterus around the time of ovulation, allowing for fertilization to take place in the body. This procedure requires a sample containing at least 1 million moving sperm. This may be an option for men who have reduced but not absent sperm production after treatment, or can be done with sperm that was frozen before cancer treatment. Intrauterine insemination, or IUI, can also be done with donor sperm for women who are single, women in a same-sex couple, or women whose partners do not make sperm. In vitro fertilization, or IVF, is the process by which ovaries are stimulated using injectable medications to grow and mature a large group of eggs at one time. Those eggs are then removed from the body and can either be frozen as unfertilized eggs or fertilized with sperm to create embryos. This is often the best option for men who have very low sperm counts or a limited amount of sperm frozen before cancer treatment, women who've had surgery to remove the fallopian tubes, individuals who have failed less invasive treatments, or anyone desiring genetic testing of embryos before pregnancy. And so you can see here, these are kind of a before and after picture. So this picture on the left is an ovary, just normal resting ovary without stimulation medications. And this ovary on the left is what a typical ovary looks like at the time of egg retrieval. So you can see these, what were these tiny little black circles here, these follicles are now much larger and each one should contain a mature egg inside. Once the egg retrieval procedure is performed, which we'll talk about on the next slide in more detail, and the hormone levels go back down to normal, the ovary will go back to looking like this about 2 weeks after the treatment is completed. So once the ovaries have been stimulated, like we saw on that last slide, eggs are collected from the body through a procedure called an egg retrieval. This is typically done with IV sedation, so the woman is asleep through the procedure. A needle is then passed through the wall of the vagina and under ultrasound guidance goes into each of these follicles or fluid-filled sacs in the ovary, removing all of the fluid, and then with it, that egg floating there in the middle. As the fluid is being collected, it is immediately handed off to the embryologist in the lab, who uses a microscope to find the eggs and separate them from the fluid. By the time the procedure is done, then we know the total number of eggs that have been obtained. Those eggs can then either be combined with sperm to be fertilized or frozen as unfertilized eggs for later use. Ovarian stimulation for IVF typically begins with the beginning of a menstrual period and lasts about 2 weeks. However, it can begin at any time during the menstrual cycle if needed due to time constraints such as the need to start treatment for a cancer recurrence or preparation for a bone marrow transplant. For women with hormone-sensitive cancers like breast cancer, additional medications are used to keep hormone levels low in the range they would be during a normal menstrual cycle if we weren't intervening at all. When these medications are used, studies have shown no difference in cancer progression or recurrence compared to women who did not go through fertility treatment. Additionally, ovarian stimulation can be done without the need to remove long-acting birth control methods such as a Nexplanon or an IUD. For those who may be experiencing a decline in ovarian reserve after treatment but are not yet ready to pursue pregnancy, egg freezing may be an option that can leave open the possibility of biological children in the future. Success rates now with frozen eggs are equivalent to outcomes with IVF using fresh eggs. It's important to note that once oocytes or eggs have been fertilized to create embryos, both partners have equal legal rights over the future use and disposition of those embryos. Therefore, because relationships can and unfortunately do sometimes change, it is generally recommended that women who are not wanting pregnancy right now freeze eggs to be fertilized at a later time when she's ready to pursue pregnancy, regardless of her relationship at the time of initiating treatment. I will note, however, that Nebraska is unique in that married partners do have legal rights over unfertilized eggs and sperm as well, although I am not aware of any successful legal challenges to their use at this time. Once pregnancy is desired, fresh or frozen eggs are fertilized with sperm from either a partner or donor to create embryos. One embryo at a time can then be transferred into the uterus using a small catheter. You can see here on this ultrasound image, this bright white line here is the catheter, and this whole thing here is the uterus. And so catheter is used to place that embryo inside the uterus where it will hopefully implant and result in a healthy pregnancy. Success rates with IVF and embryo transfer depend on a variety of factors, and your reproductive specialist should discuss those with you before starting fertility treatment. Additionally, when embryos are developed in the IVF lab, we have the ability to perform genetic testing if desired. So this is a picture here of an embryo at what we call the blastocyst stage, which occurs on day 5 or 6 of development. And here you have this clump of cells here that's called the inner cell mass that will become baby. And these cells then out around the edge are what we call the trophectoderm cells, and those are the cells that become placenta. So in this genetic testing process, we take a biopsy of about 5 to 10 cells from this part of the embryo out here that will become placenta. Those cells can then be tested for any known genetic mutations carried by one or both parents, such as a BRCA mutation, genetic mutations associated with Lynch syndrome, or other hereditary cancer syndromes, as well as non-cancer related genes such as cystic fibrosis. This is an entirely optional process, but is available if desired. It's also important to know that there are a lot of ways to build a family. When a patient's own eggs or sperm are not able to be used, eggs, sperm, or even embryos from a donor may be an option. Likewise, for women who are unable to carry a pregnancy themselves due to surgery to remove the uterus or other health concerns, a gestational carrier may allow them to have a biological child if desired. Finally, some individuals and couples may choose to pursue traditional adoption or fostering to build their families as well. Understandably, one of the biggest concerns that gets raised when I talk with individuals and couples about fertility treatment is the cost. These treatments can be expensive and are unfortunately not covered by insurance most of the time, although many of us are actively working to change that. For anyone with a cancer diagnosis pursuing fertility preservation or fertility treatment after cancer, there are some financial assistance programs available. The biggest of these is the Live Strong Foundation, which helps provide medications for free. Clinics like us at the Heartland Center who participate in the Live Strong program also discount the cost of the egg or embryo freezing to about half to a third of what it would typically cost otherwise. Finally, I would like to leave you with some resources if you would like additional information. I'm a firm believer, again, that knowledge is power. And the more you know about your own reproductive function, the more you can make empowered decisions about if, when, and how you choose to build a family or not on your own terms. There are a lot of good resources out there. And one of the leaders in this field is the Oncofertility Consortium, which is an international multidisciplinary network of clinics, hospitals, physicians, and other healthcare providers collaborating on research and best practices to improve fertility preservation and treatment options. They have a ton of good resources for patients and families navigating what can sometimes be a very overwhelming process. So if you go to their website, you can search for fertility preservation specialists in your community, as well as access a wide variety of free materials and resources. Here are just a few of those other resources available out there as well. So thank you so much for your time and attention. I look forward to answering your questions.